Carcinoma penis spreads in a very orderly way from the primary to the superficial inguinal lymph nodes, and then to the deep inguinal lymph nodes, and then to the pelvic lymph nodes, and then distant metastasis. There's no way a patient can have distant metastasis without lymph node metastasis, and also there's no way a patient can have pelvic lymph node metastasis without inguinal lymph node metastasis. This offers a potential for cure if we can achieve good control in the groins. So, management of groin forms the most crucial part of management of carcinoma penis. Not that this would matter a lot in the management, but just a small clarification. If a patient has a single lymph node on either side, it is CN1. Anything more than one lymph node, be it two lymph nodes on the same side or one on each side, would make it CN2. Having two lymph nodes on the same side, both mobile, would not make it CN1. A fixed inguinal lymph node or the presence of pelvic lymph nodes on imaging would make it CN3. Now, most importantly, both AJCC and EAU are very clear. No palpable inguinal lymph node is CN0. It's a common misconception that ultrasound is required to label a patient as CN0, even if no lymph nodes are palpable on clinical examination. That is not true. Ultrasound is just an adjunct, but it is a very useful adjunct nevertheless, especially in obese individuals and patients who had undergone prior groin surgeries like hernioplasties, open hernioplasties. Otherwise, in a patient without any palpable inguinal lymph nodes, it is not mandatory to get an ultrasound to label a patient as CN0. If a patient has palpable inguinal lymph nodes and we did an FNAC of the lymph node which came out as negative or reactive, the patient is defined as a CN0 and managed the same way as a node negative groin. Now, these are some non viable options for management of groin for carcinoma penis. In a node negative groin, doing a partial penectomy without addressing the groin is similar to doing a breast conservation surgery without an axillary sampling or a hemiglossectomy without a neck dissection. It is illogical, and we have enough evidence to support that a delayed lymphadenectomy when the nodes recur hampers survival significantly, and also when the nodes recur, they have a very high proportion of ENE, extranodal extension, compared to early surgical staging, early lymphadenectomy. And do managing the primary and elective irradiation of the groin instead of a surgical staging, it's not as bad as observing the groin, but nevertheless it also provides an inferior survival compared to a surgical staging. So a node negative groin has to be surgically staged. That's the best possible standard of care. And in a node positive groin, giving prolonged antibiotics assuming that these nodes are reactive from an infected primary is a very outdated practice, and it is to be avoided and discouraged. Also, there is no concept of sampling or berry picking of these lymph nodes, of these enlarged lymph nodes. It is to be avoided. It is not an accepted standard of care. So, practically almost all patients with carcinoma penis whom we see in the OPD may require a management of surgical staging if they have a node negative groin, because this EAU stratification of the primary tumor in non-invasive cancers, that is the TA and TIS tumors, which do not even invade the epithelium, obviously there is no risk of lymph node spread. If the tumor has invaded the epithelium and it has invaded the subepithelial connective tissue, even then, if the patient has lymphovascular invasion or perineural invasion or it is grade 3, it is termed as T1B. And even T1B is a high risk tumor in terms of the risk of lymph node metastasis. Even T1B requires invasive lymph node, surgical lymph node staging of a CN0 groin. Only those patients in which the tumor invades the subepithelial connective tissue without lymphovascular invasion or PNI, and it is either grade 1 or grade 2, can a discussion be made. In grade 2, which is intermediate risk, a discussion can be made and a case by case decision can be taken whether to surgically stage the groin. And low risk patients, which are PT1A, no lymphovascular invasion, no PNI, not poorly differentiated, that is grade 1, and the tumor is just involving the subepithelial connective tissue. These patients can be spared an invasive groin staging. It does not mean that these patients have a 0% risk of lymph node staging. It only means that the risk of lymph node metastasis is too low, and subjecting all these patients, majority of these patients, to an invasive nodal staging will yield a risk benefit ratio more in favor of a risk in terms of morbidity than a benefit. That is all it means. So, practically almost all patients will require a surgical staging of the node negative groin. Also, a very important point, there is no need for cross sectional imaging if there are no palpable inguinal lymph nodes. As we already saw, there is no way a patient can have distant metastasis without an inguinal lymph node metastasis. Now, there are four accepted standards of care for management of a node negative groin: dynamic sentinel lymph node biopsy, modified inguinal lymph node dissection, superficial inguinal lymph node dissection, and video endoscopic or robotic assisted procedures, MIS procedures. This is a very nice paper in which a survey, this there is global variation in the practice of any of these standards of care, but all of these four are accepted. Dynamic sentinel lymph node biopsy is different from sentinel lymph node biopsy in that sentinel lymph node biopsy basically means either, with lymphangiographic studies earlier, it was found that the most common nodes, the first echelon nodes, are these superomedial quadrant, that is zone 1, and the central zones. So only these nodes were removed or like picked, and then they were evaluated considering that they are sentinel lymph nodes. Dynamic sentinel lymph node biopsy adds a dynamic component in that a radioactive colloid or a blue dye is injected in the primary, and then the actual first echelon lymph node is removed. The main aim of DSLNB is to avoid the morbidity of a lymph node dissection, even superficial inguinal lymph node dissection, where all the lymph nodes superficial to the fascia lata in the decilus quadrangle are removed. Even that causes significant wound complications and morbidity. So, to avoid the morbidity, but at the same time achieving optimal lymph node staging, just like axillary sampling for sentinel lymph node biopsy for a head and neck tumor or a early breast cancer. The most important parameter when it comes to such limited staging procedures is the false negative rate. We do not want to miss lymph nodes with occult micrometastasis. So the FNR rates are 4 to 8%, 12% across all published literature in a recent meta-analysis. This 4 to 8% in centers which do a lot of dynamic sentinel lymph node biopsies. It takes a very long learning curve to reach this FNR of 4 to 8%, and there are obviously severe constraints on resources in most centers in the country. So, centralization, referral to centers which perform these procedures very frequently at a high volume are to be encouraged. This is a very interesting area. Modified inguinal lymph node dissection. So, in a superficial inguinal lymph node dissection, all the lymph nodes superficial to the fascia lata in the decilus quadrangle, which is a quadrangle formed from, the boundaries are quite classical, described in all textbooks, are removed. So, as we saw earlier, the lymphangiographic studies proved that most lymph node spread occurred in zones 1 and 5, that is the superomedial and the central quadrant near the fossa ovalis. There were literally no solitary lymphatic spread to the inferior quadrants, quadrants 3 and 4, which meant these quadrants had lymph nodes only if zone 1 and zone 1 or zone 5 had lymph nodes. So this was the basis for the formation of modified template of inguinal lymph node dissection, MILD, where there is no dissection lateral to the femoral artery and no dissection inferior to the fossa ovalis. Only these lymph nodes, but in addition to SILD, even the deep inguinal lymph nodes in this area, deep to the fascia lata, are removed and subjected to frozen section. As we saw earlier, the most important parameter in such limited staging procedures will be an FNR. Earlier literature suggested an FNR as low as less than 5.5%, but more recent literature suggests an FNR of 15 to 20%. But in an extremely beautiful paper from TMH, where between 2013 and 2019, though it is a retrospective analysis of a well maintained data set. About 146 patients, intermediate and high risk node negative patients, were evaluated. So earlier during the study period, where the global standard of care was SILD, so a lot of SILDs, mainly SILDs, were performed. So in the later part of the study period, when the global practice changed from SILD to MILD, the practice in TMH also had changed from SILD to MILD, and a lot of MILDs were performed. And it was at the end of the analysis, a total of 5 groin recurrences were found, and all 5 groin recurrences were in the MILD group. So, which means that these 5 patients had groin positive lymph nodes which were missed by the MILD. So, the groin recurrence free survival and the disease free survival were lower in the MILD group, and the FNR was 26.3% for the MILD group, and it was practically 0% for the SILD group. Interestingly, very interestingly, complications wise, complications were more in the SILD group, but as I said earlier, more SILDs were performed in the earlier part of the trial, earlier part of this study duration, not the trial, study duration, where the global standard practice was to take an S shaped incision or a vertical incision for an SILD. It was later realized that the transverse incision decreases flap complication because it preserves the blood supply for the flap better. So it is hypothesized that the S-shaped incisions used for the SILD were the reason for the increase in the complications seen in the SILD arm rather than the SILD per se compared to the MILD. So the conclusion of this was an SILD that is performed via a transverse incision should be the standard of care for staging C and 0 groins, node negative groins, in centers where dynamic sentinel lymph node biopsy is not possible. It's not validated or not possible. No resources or low volume centers. Now, in SILD, what happens is a transverse incision is placed, we raise flaps, and we remove all the lymph nodes superficial to the fascia lata in the decilus quadrangle, and we subject them to a frozen section. And if the frozen section is positive, the patient gets a completion groin node dissection, that is, the deep inguinal lymph nodes are also removed. But the question is, in India, where there are centers even frozen section is not available, in such extremely resource constrained settings, referral to a center with a frozen section is advisable, it's desirable. But if due to logistic reasons the patients do not want to go to another center, and if SILDs have to be done in centers without frozen section, then what we can do is we can do an SILD and we can send for final HPR. And on the rare occasion that the final HPR shows a positive lymph node in the SILD specimen, we can address the deep inguinal lymph nodes by radiation, because we will not be able to make the same incision, raise the same flaps, because there will be a gap of at least 10 days between this procedure of SILD and the final HPR. So this wound would have healed at least partially. So making the same incision, raising the same flaps again to do a GND will lead to disastrous wound complications. And so we can, in such severely resource constrained settings, we can do an SILD, send for final HPR, and if the final HPR is positive, we can irradiate the deep inguinal lymph nodes. Now, MIS techniques, enough evidence has accumulated for supporting safety of MIS techniques, either robotic or laparoscopic, in groin node dissections, at least for node negative groins. There is no strong evidence to support safety of such procedures in clinically node positive groins. And by logic, they cause lesser wound complications, but lymphatic related complications, basically lymphedema and lymphedema, is related to the number of lymph nodes that are removed. That has nothing to do with the incision or the placement of a trocar. So, lymphatic related complications are going to be similar to our open staging procedures. Now, we are done with the management of a node negative groin. Management of a node positive groin is fairly straightforward. Each groin is to be viewed as a separate unit. For example, in this patient, there is a solitary, the CN1 groin, it's a solitary, palpable, mobile inguinal lymph node on the left side, On the right side is CN0. So we can do an FNAC of this lymph node. If it is positive, we can straight away plan the patient for a left-sided groin node dissection, that is superficial plus deep inguinal lymph node dissection. Now for the right side, this patient is CN0. So we need not do a GND for this side. We can do a staging procedure, that is an SILD, and send it for frozen. And if the frozen is positive, we can do a completion GND. And if the SILD frozen is negative, we can get away with SILD only on this side. And on either side, if the deep inguinal lymph nodes are also positive, especially if the Cloquet's node, that is the medialmost lymph node, um, that is the lymph node that is just medial to the femoral vein at the apex of the femoral canal. If that lymph node is considered as a transition between the inguinal lymph nodes and pelvic lymph nodes. If the Clockett's lymph node is positive on frozen section, we may consider a pelvic lymph node dissection. But that can be done at a later setting also. Via a laparoscopic approach, bilateral PLND can be done. Now, this is all fairly straightforward. The two more interesting or controversial areas in the management of a node positive groin are when to do a prophylactic pelvic lymph node dissection. That is, in this patient, for example, there are no pelvic lymph nodes enlarged on imaging. Do we need to address the pelvis? When to do, what are the indications for doing a prophylactic pelvic lymph node dissection? And the second is in patients with bulky lymph nodes, whether to operate upfront or to give neoadjuvant chemotherapy. Now, about prophylactic pelvic lymph node dissection, there is a wide variation in practice globally, where some centers do prophylactic pelvic lymph node dissection even if one inguinal lymph node is positive, where some centers never do pelvic lymph node dissection and use radiation for the pelvis if inguinal lymph nodes are positive. And there is no evidence to support that doing the pelvic lymph node dissection improves the survival of a patient if the groin lymph nodes are positive. Doing a pelvic lymph node dissection, there's no evidence that it improves the survival over observation or over radiation. So a patient has a pathological positive inguinal lymph node. So three patients have pathological positive inguinal lymph nodes. Patient A undergoes observation, patient B undergoes irradiation of the pelvis, patient C undergoes pelvic lymph node dissection. There is no evidence to support that patient C will have an improved survival compared to patients A or B. That's a problem. In these two reports, it was found that if one or two inguinal lymph nodes were positive, there is a 0 to 6.5% chance that pelvic lymph nodes are going to be positive. Whereas if three inguinal lymph nodes are positive, the chance of a pelvic lymph node being positive rapidly rises from 33 to 67%. This formed the basis of the EAU recommendation that if three inguinal lymph nodes are positive, we should consider a prophylactic ipsilateral pelvic lymph node dissection. But that does not mean this is a rule that it has to be followed verbatim, that only if three lymph nodes are positive, we should consider a pelvic lymph node dissection. There are many other factors which would also predict the probability of pelvic lymph nodes being positive, like presence of extranodal extension in the positive lymph node density, and primary tumor grade. So, for example, if there are two lymph nodes that are positive in the groin with ENE, that significantly increases the chance that a pelvic lymph node is also positive. Or if a single lymph node in a grade 3 tumor, again, a very high chance of pelvic lymph node positive. So, this discretion has to be used in deciding when to do a prophylactic pelvic lymph node dissection. And the use of neoadjuvant chemotherapy for bulky but mobile inguinal lymph nodes. So, mobile inguinal lymph nodes or bilateral nodes are resectable. Now, there is a weak recommendation from EAU that we should offer chemotherapy as an alternative to upfront surgery in these patients. But this is a very debatable area because this is a fight between the concept of eradicating micrometastatic disease. So, if a patient has a bulky or a bilateral inguinal lymph node, it is assumed that the patient may have micrometastatic disease, and that neoadjuvant chemotherapy may help in uh, targeting this micrometastatic disease. But at the same time, the patient is resectable right now, and we know that carcinoma penis spreads in a very orderly way, And by resecting the groin lymph nodes, we may be able to cure the patient. But if we give neoadjuvant chemotherapy, and if by any chance the patient's disease progresses beyond the groin lymph nodes, we lose the window of opportunity to cure. So, this is a very debatable area, and uh, generally, as long as the nodes are mobile and as long as the nodes are resectable, it is better to go ahead and do a groin node dissection rather than give neoadjuvant chemotherapy, at least for the N2 groins. Because in this paper, again from TMH, it was found that giving neoadjuvant chemotherapy, the response rates were just 37%. So we may lose the window of opportunity to cure a lot of patients by giving neoadjuvant chemotherapy for bulky mobile lymph nodes or bilateral lymph nodes. Now, the last section, adjuvant therapy. Now, we have done the management of primary, we have done a partial or total penectomy, we have managed the groins, we staged them, and the final HPR is a pathological node N2 or N3, whether to just observe or adjuvant chemotherapy or adjuvant radiotherapy. Surprisingly, there is no strong evidence even in this aspect. A recent systematic review showed that there is no survival benefit for the use of adjuvant chemotherapy over observation alone for pathological node positive PN2, PN3 groins. So, the AU guidelines recommend to have a discussion with the patient about the risks and the benefits of chemotherapy, at least in PN3, and take a combined decision. Whereas, if we see the recommendation for radiotherapy, the word is offer radiotherapy because radiotherapy seems to be superseding chemo in the adjuvant setting in CA penis. An earlier systematic review of 7 studies showed no benefit in terms of survival or reducing recurrence for the use of adjuvant radiotherapy. But more recent reports have suggested a benefit, especially a dose dependent benefit. For example, in Jaipuria and allies, they evaluated patients who underwent inguinal and pelvic lymph node dissection. And they chose patients who had more than 2 positive inguinal lymph nodes but no pelvic lymph nodes. And they used a radiation dose of 54 to 60 gray, which is quite higher than the conventional doses. And the overall survival was 48 months compared to 14 months with the use of adjuvant chemotherapy. With lesser doses, the conventional doses of less than 50 gray, there were a lot of infield recurrences and the survival benefit was not that much. So, to conclude, uh, penile SECs can be considered similar to head and neck squamous cell cancers, where radiation seems to be better than chemotherapy, logic wise, extrapolation from head and neck squamous cell cancers, and also level 2 evidence wise. Also, there are multiple factors which are being studied, like HPV status and mutation status, which may play a role in choosing the optimal adjuvant regimen. And most importantly, there is a very important trial that's going on called the IMPACT trial, which will shed lights on the optimal neoadjuvant and adjuvant protocols. Now, a very important aspect, in a US National Cancer Database study, a retrospective study of 10 years, it was found that only 67% roughly of patients with lymph node positive penile cancer received a node dissection. There was a 27% rate of non adherence to EAU guidelines in European and American centers. These guidelines are probably combined EAU and ASCO guidelines, and still there was a 27% rate of non adherence to their own guidelines. The reason being this: lymph node dissections, groin node dissections are notorious for complications. Lymphedema rates of 30%. These are contemporary reports. Wound infection, wound complications, very severe wound infections in 40%, and skin necrosis in 50%. So it was found in the paper that I described from TMH about the MILD. It is very beautifully described that the blood supply for the flap is basically from the 3 arteries: superficial inferior epigastric, superficial internal pudendal, and all these arteries, and they travel horizontally. And by making an S-shaped incision, we are abruptly disrupting their blood supply. And so, using a transverse incision rather than an S-shaped or a vertical incision seems to reduce wound complications significantly, seems to have a positive impact on management of GND patients. And instead of deciding a specific time to remove the drains placed in drop, it should be a volume controlled drainage, which should be removed when on 3 consecutive days if the patient has less than 50 ml drain output. And saphenous vein sparing, even in a complete GND, even if groin lymph, deep inguinal lymph nodes were to be removed, it is technically possible to spare the saphenous vein, and this seems to reduce the complications significantly. And most importantly, I would emphasize on this lymphedema prevention, because long term complications, severe lymphedema. So, this lymphedema prevention has to start from day one of post op. Massage, skincare, DVT stockings, regular exercises, and regular physiotherapy help in preventing this long term complication.